this. We are developing a mobile application for clinical guidelines. But maybe I need to also give you a little bit of context into this. When I was just thinking about this presentation, something just came into my mind, and I was kind of attempted to consider this. This is a statement from HIFI, Health Information for All, which I'll take time to read word by word for those who cannot see it from there. It says, every day, tens of thousands of children and adults die needlessly for want of simple, low-cost interventions that are often locally available, but simply not provided in time. A major contributing factor is that the mother, family giver, or healthcare worker does not have access to the information and knowledge they need when they need it, and to make decisions and save lives. This is coming from HIFA. There was a movement or a project called HIFA. So basically, why I thought about this, it almost came closer to what we are trying to achieve. And I tried to think about it from a global perspective to see what are the challenges that we are facing at a global level. And I was fortunate to say there are organizations or institutions who have acknowledged that we've got this as a global problem, where they are saying tens of thousands of children are dying because the family giver or healthcare worker does not have access to the information and the knowledge they need when they need it to make appropriate decisions and save life. Further to that, I just thought again for my country, Zimbabwe. This is Zimbabwe cholera deaths at 24 as of September 13, 2018. This is a press release. So I just took part of the report, which says the death toll from a cholera outbreak in Zimbabwe has risen to 24, with first-line antibiotics struggling to treat the disease, which has spread from the capital, a WHO report said on Thursday. The current reports currently states something around 54 people to this date who have died of cholera. So when you look at this, cholera is a preventable and treatable condition. But sometimes you'd find that healthcare professionals and the people may not have access to the information and the knowledge they need to save lives. This is another classical example of why people are dying, because of lack of access to knowledge to save life. So it's not just access to knowledge to say the knowledge is there, but is it provided in a format and in a way which can make people be able to access it when they require it most. So we thought about coming up with a mobile application to complement as part of our African Health Digital Repository. Why we thought about this intervention as a perhaps worthy intervention within our circumstances. As reported in Zimbabwe, mobile penetration rate for Zimbabwe is reportedly at around 95%, with the majority of people having access to smart gadgets, smartphones and tablets, which is also a plus. It means that the infrastructure is already there. People have personally and individually invested in these smart gadgets. Again, you would find that clinical guidelines are mainly produced in print, sometimes not really available and accessible. You would find that in certain instances, you get to maybe a hospital with hundreds of healthcare workers. You would have maybe 15 or 20 or 30 copies of clinical guidelines. Are we assured that every healthcare professional has got access to that knowledge when they need it to make appropriate decisions and saves life? And you'd find that the significant population of healthcare professionals are failing to access or use the knowledge for clinical decision support. So this is part of a wider array of issues around the background in which we thought that this could be an important intervention. So here, that's why we are saying mobile application development as an intervention to support access to knowledge for clinical decision making. So this is just basically what a mobile application is. Not to suggest that anyone doesn't know it, but really to just give it a logical flow and context, really to say we are simply talking about a freeware-based mobile app, and you'd find that it facilitates real-time searching for the best available research evidence to inform healthcare decisions. And more often than not, you find that these are available at the point of patient care. In other words, we're saying these are point of care resources. When we're saying point of care resources, we're saying where the healthcare professional is, the person has got access to that evidence right away to make decisions and save life without delay. Then these are available or accessible via smartphones and smart gadgets. So within our project, in addition to some of the global aspects that I mentioned, to the local challenges that we're facing in Zimbabwe, we thought again that this also dovetailed quite in meaningful terms with the vision of the ministry in Zimbabwe. It's also providing, it also seeks to increase access to point of care resources within our healthcare delivery system. I have put an example of EDLIS. What I put in the bracket here as EDLIS. Our Ministry of Health provides access to what we call essential drug lists in Zimbabwe. These are documents which are routinely produced where there is new evidence that comes in. And these are some of the documents that are predominantly produced in print copies and distributed to hospitals, government hospitals, district hospitals, central hospitals. And we are saying now people are failing to adequately access and utilize these resources at the point of care. This also endeavors to support evidence-based healthcare. This is talking about the use of research evidence or clinical evidence to support clinical decision-making. So this is part of our thrust to say we think that our interventions will help support evidence-based healthcare. We would also seek to provide access to locally generated contextual evidence. I'm part of the HIFA group. There was someone at some time who posted, very controversial though, in certain circumstances, something which he captioned, when will developing countries stop importing knowledge? That was the title that he wrote about. So people came in from various angles discussing issues around that. People were suggesting that, is it really a problem for developing countries to import knowledge? Why can't developing countries consider on how they can repackage and contextualize this knowledge? Someone also said, even developed countries, they've also explored ways in which they could benefit from developing countries. And by benefiting from developing countries, that what they are concerned about the type and nature of knowledge which they can benefit from developing countries, which can also help develop their economies. So there were quite varied opinions and views which were elicited from that kind of discussion. But really one thing which I also noted, which to a certain extent is partly, I'm saying partly, important from that kind of presentation, that debate, is access to locally generated and contextual evidence. You would find that our ministries, our researchers, they are doing quite a lot in terms of knowledge resources that support not only clinical decision, but even decision making or even improve our lives as people. But you would find that access and utilization of that which is developed and generated within our developing countries is a big challenge. You would find that more often than not, someone is met with a dollar sign. I've met researchers at my institution who publish with our journals in Zimbabwe. When they want to download their own article, they are told $15 to download their own article. But we're talking about knowledge that supports development, socio-economic development of our people within our own countries. But people are not able to access and utilize that knowledge. So the intervention of thinking around coming up with mobile application, we thought that this is an intervention that can also help us to provide access to critical mass of locally generated knowledge that support clinical decision making and also help healthcare delivery within our own context. Not to say we cannot use other knowledge that come from other countries, but it's also critical to have our own critical mass of knowledge. So we believed that developing such an app and utilizing the knowledge available will also enhance healthcare delivery within our own context. So this approach again will also help us improve healthcare outcomes for the people by supporting clinical decision making and also provide 24/7 access to evidence in support of clinical decision making. So these were the major issues around our idea of thinking to come up with this intervention. So what is it that we have so far done? So our project is a partnership with the University of Zimbabwe and also the Ministry of Health and Child Care. So we've got a committee at a broader level that is spearheading the implementation of the digitization project. But in addition to that, we realize these peculiarities of developing this mobile application, and we developed what we call a technical working group, particularly for the mobile app development. So this is a technical working group that meets every month to deliberate and come up with agreed positions and also track progress in whatever we are doing. So basically what is critical is that this technical working group is comprised of healthcare practitioners. These are represented even at the top level from the ministry. Our ministry has got representatives from maybe maternal and child healthcare, public health, pharmaceuticals, and so forth. So these are part of the people who are also part of this group. Then the ministry is also part of this as well, and we have also roped in industry and commerce. Particularly of interest is ICT and IT companies. Our view is we've seen so many projects that are come up within our countries. You'd find that people get their own project, their funding, they think that they're doing something new which others have not done previously. They're operating their own silo, they do whatever they are doing, the project ends and it collapses there. But when you look at impact, what has been the value to this intervention to people's lives, you'd find that perhaps if they had spread wide, they perhaps might have, if possible, crowdfunded for more resources from companies and organizations which are also interested. So we've thought that this is critical for us to also include industry and commerce, because this is also running on a technological platform, so that at least we spread the net wider and involve every stakeholder who has got an interest into this, so that at least we have got a wider impact. So in terms of target group for the use of this clinical, application, we include doctors, nurses, pharmacists. In other words, we include all healthcare professionals in Zimbabwe. And we've also included the healthcare funders and technology industry as part of the target group for this mobile application. Then progress to date, as far as from the technical working group is concerned, we had meetings around pre-plan. We actually came up with this structure in terms of how we want to go through the journey of developing the mobile application, launching it, and looking at its value and impact. So the stages that we've actually gone through is the first, the second, and the third stage. We are now cascading into building a prototype, designing and developing of the app, which is the next stage, testing the mobile application and launching it. But after we have launched it again, we have also considered that we'll also need to have an impact assessment. So in the use of the mobile app will also enable research into evidence-based practice by addressing some of the questions. I've just put a few of the questions that we think could be of interest to say, what questions were people asking in terms of clinical questions which they were requesting to get answers from? How frequently is the app downloaded and utilized? We would want to get metrics on downloads, how it has been used for, kind of like, with the idea so that we would be able to get, if possible, gaining testimonials again from the people who have been using, to say they can be able to say, we're able to get this information which we use to maybe treat or support this decision making, and the outcome was 1, 2, 3. So that at the end of the day, we'll see the value and the impact of the intervention that would have brought in. So basically, this is the journey that we have actually gone through. We're still at an early stage, but this is the thought behind the development, the need to come up with a mobile app, what with an envisage that it will be able to do, the stakeholders that we have involved, and we are hoping that within the next 3 to 4 months, we'll be able to actually launch the mobile application. So this is basically my presentation to stimulate debate and discussions around this intervention within our circumstances, or even sometimes within your own circumstances. You remember that this digital health repository, we hope that it extends beyond the funding period. So some of perhaps best practice or interventions that might be implemented in one country may equally be able to be implemented in another part of the world, basing that whether if we are able to actually gain the necessary support both in funding and also at policy level. I thank you very much.